Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by Encore Research Group and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, moderating an episode of MedEvidence that involves Dr. Steve Toenjes and our talk about headaches and migraines in particular. And this is our third session. And we want to talk about research now. We are research guys. We've been doing this for a long time. You've been very involved here at our research center in Jacksonville, Florida. And we want to know what the latest and greatest is and some of the concepts that are being considered to help people with headaches, particularly migraine headaches, which is a huge source of lost productivity and disability. So we had some interesting discussions in the last session, and including the use of Botox for headaches, and we're going to talk a little bit about that because we actually have a clinical trial that's looking at that. And we also talked about the groups of patients that are just not getting where they need to get with current therapeutic modalities. So maybe you can start the conversation by telling us the group of patients that are not getting where they need to get despite some of the advances we've already made.
Well, certainly, our headache clinics have patients that we're having trouble, getting their headaches under control. That's relatively uncommon with the mixture of therapeutic options that are available. We generally eventually are very likely to get someone's headache syndrome under control, whether that be a mixture of things, but it usually happens. But there's still patients that we're not sufficiently successful with, and so there are more things to consider with development of new therapeutics. There are novel approaches that I think it'll be very helpful to see some of the things that are kind of in the pipeline. Maybe have demonstrated efficacy and safety through the process of clinical trials, and then become additional options.
Now, you mentioned in the last segment that the class of CGRP antagonists, calcitonin gene-related peptide, I think is the acronym, are successful up to 50 to 70% in terms of preventing migraine headaches, which would infer to me that there's still a 30 to 50% rate of migraine headaches in some patients.
Yeah.
Are there any special characteristics of those people that don't seem to respond to CGRP antagonists?
No, I don't think we can really predict that right now. Maybe in the future, if there are some pharmacogenomic type studies that investigate these sorts of things, and there are some early studies. I'm not aware of any with CGRP-based drugs, but other therapies. There are some pharmacogenomic information that we can in the future perhaps may be able to use, but no, it is a trial and error thing. This calcitonin gene-related peptide, or CGRP, is something that is very central to a lot of what goes on in our brain with the disorder of migraine. It is a neuropeptide that exists in all of the C fiber or pain fibers that are throughout our body, and those very heavily innervate our meninges and
lining of the brain,
and that the process kicks off a strong CGRP release out at the level of our meninges that then stimulates the trigeminal sensory innervation that is alongside to really kick off a lot of what happens in a migraine, the dilation of the vasculature. This is what's responsible largely for the neurogenic inflammation and likely even breakdown in some vascular permeability and mast cell degranulation, all happening largely at the level of our meninges, kicked off by more and then stimulating more central pain pathways.
So just to get into that a little bit more, particularly from my standpoint as a cardiologist, so this has to do with intracellular calcium regulation
It will.
Yeah, and calcium channel blockers do work to some degree for migraines. Is there any relationship between calcium channel blocker success and CGRP excess?
Not that I'm aware of.
Okay.
Not that I'm aware of. And so we will have, some of the calcium channel blockers would be in the category in the previous section we referred to as oldies but goodies that are also cheapies.
Right, gotcha.
And there actually are some pharmacogenomic data, particularly with verapamil. That sort of stuff is in terms of predicting the likelihood of a response to verapamil. And that's not really ready for prime time in a clinic, but those sorts of research data are extremely interesting and probably will in part be kind of the future of headache practice, I believe, eventually. So it would be nice to be able to predict what you will respond to and what you will likely have side effects to.
But we're not that good at
We're not that good yet.
Yeah. What we like to do in MedEvidence is talk about what we know,
Yes.
what we don't know,
Yes.
and how we're going to learn about what we don't know.
Yes.
So one of the things we don't know is predicting who's going to respond to which category of drugs.
Correct.
Okay.
Yes.
So let's get to one of the categories, Botox.
Okay.
So Botox is not thought of necessarily as a headache drug,
Okay.
but it works, doesn't it?
It sure does. It's one of our most effective treatments. Specifically, currently it's FDA approved for chronic migraine patients. Chronic migraine patients being patients that have headaches on more days than they don't have headaches, and at least 8 of them in a month become migrainous. That's really what we mean by chronic migraine, as long as that's gone on for a duration of at least several months. Now, we say Botox, and everybody knows the name Botox, but Botox is a trade name. And so it's onabotulinum toxin A is sort of the name of what Botox is.
Easier to say Botox.
It is. Once you practice onabotulinum toxin A a few times, you can kind of get it to come out. And so there are numerous botulinum toxins, and Botox or onabotulinum toxin A is the one that's FDA approved for chronic migraine. And there are other toxins that have different FDA approvals. And one of the studies that we'll be entering into is a different botulinum toxin and addressing specifically both episodic and chronic migraine patients. And so that's very exciting, I think, as a potential option and a new botulinum toxin therapy that may demonstrate efficacy, safety, and hopefully, if so, then be FDA approved.
Okay.
Yeah.
So now I call it botulism toxin. Does it really matter if you pronounce it that way, or botulinum?
I think everybody knows what you're talking about.
Okay.
It is a therapy that is seemingly fairly unconventional.
Now, do you inject it in the forehead area? Tell us a little bit more about the details.
It is a procedure. The protocol for it, or we would call preempt, just named after the studies, the clinical studies that demonstrated its efficacy. Very specific, location and doses of injections. There's actually 31 injection sites in the preempt protocol. And generally, certainly in the clinic, kind of that's the way that we start. It is a protocol that's been validated through the years and adjusted, and it is one of our most useful go-to therapies for the really challenging migraine patient. Botulinum toxin is taken up by sensory neurons, and we believe that it's taken into our brainstem, actually. And one of the things that it does is it paralyzes the ability of trigeminal innervation to release CGRP and other therapies, other neuropeptides, but one of its likely main mechanisms of action is paralyzing the ability to release that CGRP substance out in our meninges
and just for the lay audience, trigeminal is the nerve that affects the eyes and the face and
is responsible for all of the sensory innervation of the lining of our brain or the meninges.
Right.
Yes.
So how does the protocol differ when you're using botulism or botulism, however you pronounce it, toxin for cosmetic purposes versus neurological purposes?
So, well, botulinum toxins are capable of influencing sensory neurons the way that I just mentioned, but they also weaken muscle. They prevent motor neurons from being capable of stimulating a muscle so it can contract, and it is a way that you can get rid of a wrinkle. Is you can weaken the muscles that are producing those wrinkles.
Gotcha.
And that has been something that has been, known and done for a very long period of time. And the observation was made with a plastic surgeon who was doing cosmetic botulinum toxin injections and realized, while one in five females is a migraine patient, a pretty consistent report that, hey, with this cosmetic stuff, my migraines are really getting better. And then, lo and behold, here come the studies in migraine with demonstrated
And the
efficacy.
protocols are the same for the different indications?
No, the doses are going to be much higher for migraine.
Okay.
And so that's an important point. When we're doing cosmetic, we don't do cosmetic injections, but when cosmetic injections are being done, they're done in different locations and generally at a much lower dose than what we are using for migraine treatments.
Is it a problem that people that get prescribed the toxin for neurological purposes use it off-label for other things? Is that an abuse of the therapy?
We discourage that, and the main reason one of the main reasons to discourage that is we need to understand that this is a toxin that it is possible for our immune system to respond to. And so we could develop antibodies to botulinum toxin A or any other botulinum toxin. And if our immune system really responds to it and develops high concentrations of antibodies to it, that therapy is not going to work for us because our immune system will gobble it up as soon as we inject it.
So undermine your own purposes.
Correct. And so the protocol of injection every 12 weeks seems to work well at reducing the likelihood of development of antitoxin antibodies. And mixing that up really does run the risk of stimulating our immune system and backfiring on the patient. And so the botulinum toxin has a lot of utilities. And, there are patients that require it for bladder issues. There are heart-related studies with botulinum toxin. If there is another indication or a person is doing cosmetic injections along with migraine-based injections, we just really strongly encourage them to have those done pretty much on the same day or within a day of each other.
Interesting. Very interesting.
Yeah.
So let's move to another area of research. So
Okay.
what else is going on in terms of treatment for refractory patients that have migraines or other headache syndromes?
I think it is part of what we will share with patients who are, one of the most difficult things is when the patient gets defeated and and has a loss of hope. There are other novel compounds, PACAP or pituitary adenylate cyclase protein that seems to potentially maybe have some significant pathophysiologic relevance to migraine, and it is a completely novel therapeutic that we've participated in some of those trials here, and there are more with various pharmaceuticals planned for the future. And so that's a completely unique mechanism of treatment that may come around the bend. Hopefully, it will be
Nothing on the market yet.
Oh no PACAP inhibitors on FDA approved at this time. And then in terms of relatively unique, I think is one of the studies that we'll be participating with a therapy that impacts prostaglandin pathways. Prostaglandins are a very important part of inflammation and pain, and can influence vascular tone as well. And so there are novel prostaglandin-based preventive therapies that we'll also be studying here in the near future. And so the general message for the migraine sufferer who has not had a sufficient response to a variety of therapies is to understand that the research world is inventing and continues to address and try to come up with new strategies for those patients that we've not been that successful with in the past.
Sure.
Yeah.
So you're a clinical trial guy, and you see lots of these patients. So when do you approach a patient about getting involved in clinical research? Obviously, I would think that somebody that has a great response to something that's already out there is probably not going to be the best candidate. On the other hand, it sounds like there are people that go through your headache clinic that would be great candidates. So give us a little insight into how you approach that and why you would choose a particular type of patient for this discussion.
There seems to be a personality type that's interested in investigation, and patients who understand the landscape of treatments, then pointing out to them that there are newer treatments that just like all of our CGRP-based therapies, 7 or 8 years ago, they were all in clinical trials.
And we saw plenty of people during the development of those drugs that got huge benefit.
Yes, absolutely.
Yeah, even though a lot of these studies are placebo-controlled, sometimes there's an open label portion of the trial where everybody gets access to it. But it's obvious in some cases who's getting the therapy and who's not, quite frankly.
It is.
Yeah, especially in something symptomatic.
Correct.
Right.
One of the things that's true about and a challenge in the migraine study world is that looming placebo effect, and so it can be difficult to really tease out. But sometimes therapies are
which is
so
okay.
effective.
Again, if the placebo works for you, that's great. We love that too.
There you go.
All right. But in some people, it's so profound how much different they feel after they participate in a trial that you have to think the therapy has something to do with it.
There was a wise individual who made the statement, if you're having trouble getting control of somebody's headaches, one of the best ways to get them under control is enroll them into a clinical trial.
There's no question about that.
It's sick.
Well, there's other parts of it. There's the
Sure.
nurturing part of it. There's the reinforcement of dietary issues, of avoiding triggers, all these things that you've already brought up. So the clinical research process is extremely helpful for a lot of people.
Absolutely. I think so.
So is there anything else out there that we should be aware of in terms of maybe research that is not being done here in Northeast Florida that we should be looking out for, or other things that may be a particular niche for a particular type of headache patient?
We always hold the cluster headache patients in a very specific niche, and so I do think that it's the cluster headache patients are always waiting for additional studies to come out, and so maybe some word or mention about nerve stimulation devices and all, those types of therapies that are not really medicines. I think that unfortunately it's difficult for nerve stimulators, and there are transcranial magnetic stimulators and other types of therapies devices to really get traction with insurance coverage.
Are there any devices approved now for migraine headaches?
Oh, yes.
Can you mention those quickly?
Sure. So a transcranial magnetic stimulation device. It's
really?
An e-neura. It gives it's approved for both abortive therapy and prevention, and has demonstrated efficacy. Is
Do you wear this? You have to go to a clinic to get it, or
that's the problem. Is you got to rent it or purchase it, and it's generally cost prohibitive. And there are other nerve stimulation devices. A lot of people will have heard of Cephaly, which is just an electric stimulation device that really can help some patients. And so, I think as the efficacy of these sorts of things becomes increasingly, more and more demonstrated, hopefully coverage will be a little more reasonable. It's unfortunate if I think that the transcranial magnetic stimulation device companies have largely kind of given up on the United States at the
Really?
moment, but it is a safe therapy, and it has good efficacy.
Interesting.
And so,
And that's they've given up in the U.S. because of payment issues.
right.
Wow,
Yes.
Interesting. And how about narcotic avoidance? I know that's a big push by the government and others because of all the side effects of chronic narcotic use.
Yes.
Are there studies that are specifically focused on that?
So first, if you're going to a provider and you have a migraine syndrome and what they're prescribing for you is a narcotic, you should I think that you should maybe seek an additional opinion. Narcotics are almost never appropriate for a migraine patient.
Interesting.
Narcotics really don't abort migraines. I say, in my opinion, no narcotic has ever aborted a migraine ever.
Wow.
It may allow someone to go to sleep, and then sleep would have then aborted the migraine, but it wasn't the actual narcotic effect. As a matter of fact, narcotics will run a very high rate of backfiring on a migraine patient and producing that medication rebound phenomenon. It's extremely potent at actually making a migraine patient worse.
Wow.
And so we almost never are prescribing
And that's a big
narcotics.
change. So when I was a medical
Tremendous.
resident, I used to be taught to give Demerol in
Right.
the emergency room. That
Yeah.
was supposed to be the best narcotic for migraine patients.
Yes.
Obviously, that turned out to be incorrect.
It was very incorrect.
Okay.
Yes. We have learned this for sure over the last 20, 30 years. And we really should be avoiding narcotics because we have, we understand migraine pathophysiology a lot better now. And these migraine therapies are migraine specific therapies. I mean, they are directed at the pathophysiology of migraine. And that's why they're so much more effective.
But I understand there is still a group of patients that are being prescribed narcotics because of, quote, headaches. And
Certainly.
that could be a target maybe for clinical research, I would think.
Historically, you'll find in most clinical trials that patients who are on frequent doses of narcotics are going to be excluded from those studies. And the conventional, consultation, in terms of designing studies, would generally suggest that because nothing's going to work in that scenario.
Right.
The first thing that really needs to happen is the narcotics need to be weaned. And so approaches to actually get rid of what's very likely an offending agent worsening a headache syndrome, that's actually what needs to be done. I would be surprised to find pharmaceuticals interested in studying that population because
unless it can help people get off narcotics more easily as an endpoint for the study.
Absolutely. Very, very useful. Yeah. And it is a challenging situation. It's really difficult when the person has another pain condition that really does justify the narcotic use.
Sure.
And so those are some of our most challenging headache patients for sure.
Well, thank you. Steve, this has been a fascinating conversation. It's been absolutely fabulous. I've learned a tremendous amount. Hopefully our audience will have learned as well. Thank you for being part of MedEvidence.
You're welcome.
Thanks for joining the MedEvidence podcast. To learn more, head over to MedEvidence.com or subscribe to our podcast on your favorite podcast platform.